Before we begin, please note that the information in this video is for educational and informational purposes only and reflects personal experiences in a specific online nursing program in the United States. It is not intended as a substitute for professional career, academic, or financial advice. Every nursing program has different requirements, structures, and outcomes. You should always consult with accredited educational institutions and professional advisors to determine the best path for your individual circumstances and career goals. It's 5 o'clock in the morning. The only sounds are the hum of the refrigerator and the frantic beating of my own heart. Outside, the world is dark and silent, but in here, under the glow of a single lamp, a battle is about to begin. My opponent? A 300-page chapter on cardiac pharmacology. My fuel? A lukewarm cup of coffee that tastes like desperation and ambition. This is the moment nobody sees. This is the reality of online nursing school. Most people hear online school and picture someone in their pajamas, casually clicking through a slideshow with a sitcom playing in the background. They think it's the easy way out, the shortcut. Let me tell you, right now, that is the biggest myth in modern education. There are no shortcuts in nursing. There are no easy paths to being the person holding a stranger's life in their hands. The only difference is that my classroom is this kitchen table, my study partners are in a chat window, and my biggest challenge isn't just learning the Krebs cycle. It's learning it while my toddler is having a meltdown in the next room. If you've ever wondered what it truly takes to get a nursing degree online in the USA, you're in the right place. I'm pulling back the curtain on the entire process. No filters, no staged study sessions with perfectly organized notes. You are going to see the chaos, the stress, the exhaustion, and the moments of pure, unadulterated joy that make it all worthwhile. By the end of this, you won't just see a day in my life. You'll understand the grit, the strategy, and the sheer force of will required to make this dream a reality. You'll have a clear, honest picture that will help you decide if this demanding, but incredibly rewarding path is the right one for you. So let's start with that 5 a.m. alarm. It's not a gentle chime. It's a blaring signal that my most valuable resource time is officially ticking down. Before the sun is up, before my family wakes up, this is my sacred window. I call it the hour of power, but most days it feels more like the hour of panic. My brain is still foggy, but the information I have to absorb is crystal clear and unforgiving. Today, it's beta blockers, ACE inhibitors, and calcium channel blockers. I'm not just memorizing names. I'm trying to build a mental map of how these drugs navigate the intricate highways of the human body. What do they do? Why do they do it? And most importantly, what are the subtle signs that something is going terribly wrong? I use a technique called active recall. I'm not just rereading my notes. I'm staring at a blank piece of paper and forcing my brain to retrieve the information from scratch. I'll draw out the heart, map the pathways, and talk it all out loud to my very confused cat. Okay, so if we give metoprolol, we're blocking the beta-1 receptors, which is going to decrease heart rate and contractility, lowering blood pressure. But what do I need to watch for? Bradycardia. I have to check the patient's pulse before I even think about administering this. It sounds crazy talking to myself in a dark kitchen, but this is how the information sticks. It's how a list of side effects on a screen becomes a life-saving instinct in a hospital room. This pre-dawn cram session isn't just about pharmacology. It's about building a mental callus. It's about fighting imposter syndrome before it even has a chance to wake up. Every single day, there's a voice in the back of my head that whispers, "You can't do this. You're not smart enough. Everyone else gets this faster than you." And this early morning ritual, this discipline, is my way of telling that voice to shut up. It's proof that I'm putting in the work. Around 6:15, the house starts to stir. The quiet focus shatters. It's a rapid transition from student to parent. Lunches need to be packed, breakfast needs to be made, and a missing left shoe becomes a level 1 crisis. This is the great balancing act. I'm mentally running through diuretic classifications while simultaneously negotiating with a 6-year-old about the merits of wearing a coat when it's 40 degrees outside. It's a skill they don't teach you in school. The ability to compartmentalize. You learn to flip a switch in your brain. One moment you're calculating a drip rate, the next you're wiping spilled milk off the floor. There's no seamless blend. It's a series of hard cuts between two different worlds. By 8 o'clock, the kids are off to school, and the house is quiet again. But now it's a different kind of quiet. It's the silence of expectation. I log into my university's online portal. This is my campus. It's not ivy-covered brick buildings and sprawling lawns. It's a dashboard of links, deadlines, and discussion boards. can feel incredibly isolating. There's no walking to class with a friend or catching a professor during office hours. It's just you and the screen. My first task is to check the announcements. This is critical. A professor might post a clarification about an assignment, a change in a deadline, or a link to a helpful resource. Missing an announcement in an online program is like missing the first 10 minutes of a lecture. You're already behind. Then I open up my digital calendar. I live and die by this calendar. Every single hour of my day is blocked out. 8:30 to 10:30. Watch pathophysiology lecture and take notes. 10:30 to 11 o'clock, review flashcards. 11 to 12:30, work on care plan assignment. Without this rigid structure, the flexibility of online learning becomes a trap. It's so easy to say, oh, I'll just watch that lecture later, or I'll get to that reading tonight. But later becomes never with terrifying speed. Procrastination is the silent killer of the online student. You have to be your own drill sergeant. You have to create the structure that a traditional campus provides for you. Today's lecture is on cellular adaptation. The professor is fantastic. A brilliant woman who can make concepts like dysplasia and metaplasia sound like a fascinating detective story. But watching a pre-recorded lecture requires a different kind of focus. There's no classroom energy to feed off of. It's tempting to hit pause to check your phone to get another cup of coffee. I have to actively fight that temptation. I put my phone in another room. I use an app that blocks distracting websites. I treat this pre-recorded video as if it's a live one-time only event. I take notes by hand, because the physical act of writing helps cement the information in my memory. I'm not just transcribing what she says. I'm synthesizing it. I'm drawing diagrams, connecting it to what I learned in anatomy last semester, and jotting down questions to post on the class discussion board later. This is the key to active learning online. You can't be a passive recipient of information. You have to attack it. You have to engage with it, wrestle with it, and make it your own. After the lecture, I don't just close my laptop. I spend 20 minutes immediately reviewing my notes, summarizing the key points in my own words. It's called the consolidation phase. It's where the learning actually happens, in that quiet moment of reflection after the information firehose has been turned off. It's the difference between temporarily remembering a fact for a test and truly understanding a concept for a career. And that understanding is immediately put to the test. Because in online nursing school, there's no gap between theory and application. It's a constant rapid-fire cycle. Absorb, analyze, apply. Repeat. The next block on my schedule isn't another chapter or a video lecture. It's a virtual clinical simulation. This is where the digital rubber meets the road. I log into the simulation platform, and the screen loads. There's no cartoonish avatar, no game-like interface. It's designed to be stark, clean, and a little intimidating, just like a real electronic health record. My patient for the next hour is a 68-year-old man, Mr. Henderson. His chart pops up. Chief complaint: shortness of breath and a crushing pain in his chest. My own breath catches for a second. Even though I know he's just a complex algorithm, the responsibility feels heavy. The clock in the corner of the screen starts ticking. My first task is to assess. I click through the digital stethoscope icon, place it on the correct points on his chest on the screen, and listen to the audio file. Crackles in the lower lobes. Not good. I pull up his vitals. Blood pressure is elevated, heart rate is tachycardic, and his oxygen saturation is dropping. It's 91%. The alarm bells in my head, the ones drilled into me from my pathophysiology textbook, are screaming. Every click matters. Every second I spend deliberating is a second his virtual condition could deteriorate. Do I administer oxygen first? Or do I get an EKG? Do I need to order blood work to check for cardiac enzymes? The simulation presents me with a dozen choices, but only a few are correct for this exact moment. This isn't a multiple choice quiz where you can guess C. This is a cascade of decisions. A wrong move here doesn't just give you a bad grade. The simulation is programmed to show you the consequences. Mr. Henderson's vitals will worsen. He could go into cardiac arrest. And I would have to watch it happen, knowing it was my decision tree that led him there. The pressure is immense. I can feel my own heart rate quicken. I start a 2-liter nasal cannula and watch his O2 sats. They creep up to 93%. A tiny victory. A small breath of relief. Next, the EKG. I click to attach the leads in the correct order. The squiggly line appears on the monitor. I'm staring at it, trying to decipher the peaks and valleys, recalling the diagrams from my textbook. Is that an ST segment elevation? It looks like it. This is it. This is the moment of synthesis. It's not about remembering the definition of a myocardial infarction. It's about recognizing its signature on a screen under pressure. I initiate the protocol I've studied. I administer sublingual nitroglycerin, then aspirin. I'm talking to the screen, to this digital patient, telling him what I'm doing just as I would in a real room. It feels strange, but it's a habit I have to build. For the next 30 minutes, I'm in a state of intense focus. I'm managing his pain, monitoring his vitals, and documenting every single action with the rationale. The simulation is relentless. It throws a new symptom at me, a sudden drop in blood pressure after the medication. Now what? Is it an adverse reaction? Is the condition worsening? I have to reassess, rethink, and react. Finally, the simulation ends. A screen pops up. Patient has been stabilized and transferred to the cardiac cath lab. I physically slump in my chair, exhaling a breath I didn't realize I was holding. Then comes the most important part, the debrief. The program gives me a score, but more importantly, it provides a detailed second-by-second breakdown of my performance. It shows me the things I did right, the optimal order of interventions, but it also highlights my mistakes. I was 6 minutes too slow in ordering the cardiac enzyme labs. It shows me the potential real-world consequence of that delay. It's brutal, but it's the most effective learning tool I have. It's a safe place to make dangerous mistakes. I'll never be slow to order that lab again. After the intensity of the simulation, my brain is buzzing. I need to switch gears, moving from that highly technical, fast-paced mindset to something more collaborative and reflective. It's time for the discussion boards. Now, if you think discussion boards are just about typing "I agree with your post," you have never been in a quality nursing program. These are our digital grand rounds. They are intellectual battlegrounds where we dissect complex case studies and ethical dilemmas. Today's prompt is about a non-compliant diabetic patient who continuously misses appointments and doesn't follow his diet, and is now facing a potential amputation. The question isn't just, what do you do? It's deeper. It asks us to explore the psychosocial factors, the healthcare disparities, the role of patient autonomy versus the nurse's duty to promote health. There are no easy answers. I spend the first 20 minutes just reading. I read the initial prompt from the professor, and then I read the responses from my classmates. This is one of the hidden strengths of online learning. My cohort isn't just a group of 20-somethings fresh out of high school. There's a 35-year-old former paramedic from Texas who brings a wealth of emergency field experience. There's a 42-year-old mother of 3 from Oregon who has navigated the healthcare system for her child with a chronic illness. There's a 28-year-old who used to be a social worker in Chicago, and her insights into systemic barriers are incredible. Their posts aren't just opinions. They are well-researched, evidence-based arguments. They are citing peer-reviewed journals, nursing theorists, and the American Nurses Association Code of Ethics. The paramedic talks about the futility he felt treating the same patients over and over in the ambulance. The social worker discusses the concept of food deserts and how a healthy diet might be impossible for our virtual patient. The mother from Oregon shares a personal story about the exhaustion and frustration that leads to non-compliance. Reading their perspectives fundamentally changes my own. I came into this thinking about education and motivation, but now I'm thinking about access, equity, and empathy. My own post has to add to this conversation. It has to be more than just a summary. I spend the next hour crafting my response. I find a research article on the effectiveness of motivational interviewing in a culturally competent framework. I connect it to the points my classmates made, challenging one idea gently while building on another. I write, delete, and rewrite sentences, making sure my tone is professional, my argument is sound, and my citations are perfect. This isn't busy work. This is how we learn to think like nurses. It's how we learn to see a patient not as a diagnosis or a problem to be solved, but as a whole person living in a complex world. We are sharpening each other's minds, challenging each other's assumptions from hundreds of miles apart. There's a genuine sense of community here, forged in late-night posts and shared intellectual struggles. We are building the foundations of our professional identities, one carefully crafted paragraph at a time. It's a different kind of intensity than the simulation, not a sprint against a clock, but a marathon of deep, critical thought. And in many ways, it's just as vital, because all this screen time, all this digital practice, is in service of one thing: the moment you walk into a real patient's room. And that transition from the controlled, predictable world of a computer simulation to the chaotic, unpredictable reality of a healthcare setting is the single biggest leap you will ever make as a nursing student. It's where the rubber truly meets the road. Because despite the online nursing student, a huge, non-negotiable part of your education happens right here, in the real world. We're talking about clinicals. Hundreds of hours of mandatory, in-person, hands-on training that no computer program can ever replace. This is the part that often gets glossed over in the brochures for online programs. They show you the flexibility, the convenience of learning from your couch. And that's all true. But they don't always highlight the monumental task of securing, preparing for, and surviving your clinical rotations. For many of us, this is the hidden curriculum, the trial by fire that happens long before you ever take a patient's blood pressure. Depending on your program, the journey to your first clinical day can go one of two ways. The first way is the guided path. Your school has established partnerships with hospitals and clinics in your region. They have a list of pre-approved sites and preceptors, and they handle most of the matchmaking. You submit your preferences and they place you. It's streamlined, it's organized, and it lets you focus on your studies. If your program offers this, consider it a massive stress-reducing benefit. Then there's the second way, the way many online students have to go, the do-it-yourself path. Your school gives you a list of requirements, the type of unit, the number of hours, the preceptor qualifications, and then they essentially say, good luck. You are now a student, a part-time project manager, and a cold-calling salesperson rolled into one. Your new mission, which you absolutely must accept, is to find a licensed practicing nurse in a qualifying healthcare facility who is willing to take on the massive responsibility of mentoring you for free for several hundred hours. Sounds daunting because it is. You start by making a list of every hospital, clinic, urgent care center, and long-term care facility within a 50-mile radius. You scour their websites for a careers or education page, hoping for a magic portal for student placements. Most of the time there isn't one, so you move on to LinkedIn, searching for nurse managers or clinical educators at those facilities. You craft the perfect professional email, attaching your resume, your school's requirements, and a cover letter that practically begs for an opportunity. You explain that you're an organized, eager, and self-sufficient online student who won't be a burden. You hit send, and then you wait. Most of the time you hear nothing. Or you get a polite, "We're not accepting students at this time." Or, "We only partner with brand-name brick-and-mortar university." Rejection becomes your constant companion. You start calling departments directly. You get transferred from one person to the next, leaving voicemails that you're sure disappear into a black hole. It's a humbling and frankly frustrating process. You're trying to get the education you've paid for, but you're hitting administrative brick walls everywhere you turn. This is a test of persistence that has nothing to do with anatomy or pharmacology. It's about grit. But then one day you get a reply. A nurse manager is willing to talk. A clinical educator asks for your paperwork. Feels like you've won the lottery. And now the real paperwork begins. A mountain of it. You need a comprehensive background check, a 10-panel drug screen, and proof of every vaccination you've had since birth, including titers to prove your immunity. You need CPR certification, a physical exam, proof of health insurance, and your own personal liability insurance. You have to complete online modules for HIPAA, bloodborne pathogens, and workplace safety for the hospital itself. It's a full-time job just getting cleared to walk onto the floor. After weeks, sometimes months of this logistical marathon, the day finally arrives. Your first day of clinicals. You wake up at 4:30 in the morning, long before the sun, your stomach churning with a potent cocktail of terror and exhilaration. You pull on your stiff, new scrubs, the school-mandated color that screams, "I'm a student," and check your bag for the 10th time. Stethoscope, check. Penlight, check. Black pens, a whole collection of them, check. Tiny notebook, bandage scissors, a granola bar you know you'll be too nervous to eat, check, check, check. Walking through those automatic hospital doors is a full-body sensory assault. The sterile, slightly chemical smell that clings to everything. The distant, urgent beep of an N4 pump, the soft squeak of rubber-soled shoes on linoleum. The overhead page calling a code you don't yet understand. It's a world away from the quiet of your home office. This is real. The stakes are real. You meet your preceptor, the experienced nurse who holds your entire grade and your future career in their hands. They might be warm and welcoming, or they might be gruff, overworked, and skeptical of the online student. Your job is to be a sponge, to be humble, helpful, and invisible all at the same time. You learn their workflow, their preferences, where they keep the extra saline flushes. You become their shadow. The first few hours are a blur of introductions and orientations. Then you get your first patient assignment. Your preceptor gives you the report, a rapid-fire summary of a human being's entire medical situation. Okay, in room 302 we have a 68-year-old male, post-op day 2 from a right hip replacement, history of hypertension and type 2 diabetes, on a heparin drip for DVT prophylaxis, needs his dressing changed, and he's a fall risk. Your brain scrambles to connect the dots. You remember the online module on postoperative care, the chapter on anticoagulants, the case study about wound management. But a textbook can't prepare you for walking into that room. You see the patient, not just a diagnosis. You see the pain in his eyes, the vulnerability of being in a hospital gown, the pictures of his grandkids taped to the wall. And you start with the basics, the absolute fundamentals of care that are the bedrock of nursing. You help him to the chair for breakfast. You take his vital signs, your hands fumbling with the blood pressure cuff, praying you get an accurate reading. You document everything meticulously, double-checking your charting. These small tasks aren't glamorous, but they are profoundly important. They are acts of service. They are how you build trust. Then comes the moment of truth. Your preceptor says, okay, his 4 needs to be restarted. You've practiced in the lab, right? You're up. Suddenly, every eye in the room feels like it's on you. The patient, his family member, and your preceptor. Your heart hammers against your ribs. You remember the steps from the online video. Tourniquet. Clean the site. Find a good vein. Anchor it. Bevel up. But the plastic arm in the skills lab didn't have rolling veins. It didn't flinch or have hair. It didn't look up at you with trusting eyes. You take a deep breath. You do it. Maybe you get it on the first try, a flash of triumphant relief washing over you. Or maybe you miss and you feel a wave of shame and disappointment. Your preceptor might say, it's okay, happens to everyone. Let's talk about what we can do differently. Try again. Either way, you've done it. You've bridged the gap between theory and practice. You've performed a real skill on a real person. This is when everything starts to click. That dry lecture on fluid and electrolyte balance suddenly makes perfect sense when you're looking at your patient's lab results and hanging a bag of potassium. The pharmacology module on beta blockers becomes crystal clear when you're explaining to your patient why you're holding their dose because their heart rate is too low. The online case study about recognizing the subtle signs of a declining patient becomes terrifyingly relevant when you notice your patient is just a little more confused than they were an hour ago. And you have to alert your preceptor. The clinical experience is what transforms information into knowledge, and knowledge into wisdom. It's where you learn the art of nursing. How to talk to a family who has just received devastating news. How to hold the hand of someone in pain. How to find a moment of humor and connection in the middle of a chaotic 12-hour shift. You can't learn empathy from a PDF. You can't simulate compassion. You have to live it. At the end of the day, you walk out of that hospital and the sun is setting. Your feet ache, your back is sore, and your brain feels like it's been run through a blender. You're mentally and emotionally drained in a way you've never experienced before. You might sit in your car for 10 minutes just staring into space, trying to process everything you saw, everything you did, everything you felt. There's a weight to it, a profound sense of responsibility that settles deep in your bones. It's overwhelming, it's terrifying, and you can't wait to go back and do it all again. Because for the first time, you don't just feel like a student, you feel like a nurse. And that feeling is what makes every single challenge, every rejection, and every exhausting hour completely worth it. But surviving this trial by fire requires more than just clinical skill. It requires a level of mental fortitude and self-care that your textbooks will never teach you. It's a curriculum that's not listed on your syllabus. There are no lectures for it, no multiple-choice quizzes. This is the shadow curriculum of nursing school. And the final exam is your own sanity. It's about learning to manage the voice in your head that, after a 12-hour clinical shift where you felt clumsy and slow, whispers that you're an imposter who will never be good enough. It's about building a callus over the parts of your heart that break a little every time you see a family receive bad news. A process that, if you're not careful, can lead to a dangerous numbness called compassion fatigue. I learned this the hard way. I remember one specific Tuesday in my second semester. It felt like the universe had conspired to test every single one of my limits. It started at 5:30 in the morning, when I realized I had misread the study guide for a pharmacology quiz. I had spent the entire weekend memorizing cardiac medications, only to discover the quiz was on diuretics and renal drugs. There was no time to pivot. I walked into that quiz knowing I was going to fail. The cold dread that fills your stomach in that moment. It's a unique kind of academic horror. That was just the appetizer. My clinical rotation that day was on a busy med-surg floor. The energy was frantic from the moment I arrived. My preceptor, a seasoned nurse who moved with an efficiency that seemed almost supernatural, was clearly stressed. She was patient, but her patience had a razor-thin edge. My first task was to insert a new for an elderly patient who was severely dehydrated. His veins were like tiny rolling threads hidden under paper-thin skin. I tried once. I missed. I could feel the patient's wince, could see the tiny bloom of a hematoma forming under his skin. I apologized, my voice sounding small and shaky. My preceptor stepped in. "Let me," she said, not unkindly, but with an air of finality that felt like a judgment. She got it on the first try, a perfect clean insertion. She didn't say, "You should have been able to do that," but I heard it anyway. The voice in my head certainly did. Screamed it. The rest of the day was a blur of small failures. I was slow charting my assessments. I forgot to grab a specific dressing from the supply room, forcing my preceptor to make an extra trip. During rounds, a doctor asked me a question about a patient's lab values, and my mind went completely blank. I stood there, mute and red-faced, as my preceptor smoothly answered for me. Each incident was a tiny paper cut, but by the end of the shift I felt like I was bleeding out. I drove home in silence, the radio off, replaying every mistake, every awkward pause, every disappointed glance. When I finally walked into my apartment, the exhaustion hit me like a physical blow. I dropped my bag on the floor, kicked off my shoes, and saw the mountain of work waiting for me on my desk. A 20-page care plan was due at midnight. I had a recorded lecture on fluid and electrolytes to watch. And I still had to study for the next pharmacology quiz, the one I actually knew the topic for. I just stood there, staring at the pile of books and my laptop screen, and I started to cry. It wasn't a few quiet tears. It was a full-body, gut-wrenching sob. The kind where you can't breathe and you think for one terrifying second, "I can't do this. I'm not cut out for this. I need to quit." That moment, that breaking point, is the final exam of the shadow curriculum. And passing it isn't about pushing through or toughing it out. That's a recipe for burnout. Passing is about learning to deploy your own mental PP, your personal protective equipment for your mind. This isn't something you're born with. It's a set of skills you have to intentionally practice, just like learning to take a blood pressure. My first piece of mental PPE is the decompression ritual. For me, it became a non-negotiable process. The moment I get home from a clinical shift, before I even speak to my partner or check my phone, I go straight to the bathroom. The scrubs, which feel like they've absorbed all the stress and sadness of the hospital, go directly into the hamper. They don't touch any other surface. Then I take a shower. It's not just about getting clean, it's a symbolic act of washing the day off. I visualize the anxiety, the self-doubt, the memory of the missed for, all of it swirling down the drain. Only after that am I allowed to emerge, put on clean, comfortable clothes and re-engage with my life. It creates a hard boundary between the nursing student and the person. The second tool is what I call data, not drama. When you're in a high-stakes environment like nursing, it's easy to internalize every piece of feedback as a personal attack on your character. The missed 4 didn't mean I was an incompetent failure. The data was, I needed more practice with geriatric patients with difficult veins. My preceptor's clipped tone wasn't a judgment on my worth as a human being. The data was, the floor was understaffed, and she was operating under immense pressure. The doctor's question I couldn't answer wasn't proof I was stupid. The data was, I needed to review my lab value ranges before rounds. When you reframe criticism and failure as simple data points, it strips them of their emotional power. It becomes information you can use to improve, not a weapon to beat yourself up with. To combat the constant focus on what's going wrong, I started a small wins log. It's just a simple note on my phone. At the end of every single day, I force myself to write down 3 things that went right. Some days it's a struggle. A win might be as simple as I drank enough water or I remembered to pack a lunch. But other days it's more significant. A patient's family member thanked me for being kind. I finally understood the RAS system. I successfully advocated for my patient to get a PRN pain medication. Over time, this log becomes a powerful counter-narrative to the voice of the imposter. It's tangible proof that even on the hardest days, You are still making progress. You are still learning. You are still showing up. Finally, and this is especially crucial for online students, you have to aggressively build your tribe. Isolation is the accelerant for burnout. You might be studying alone in your bedroom, but you are not alone in this struggle. I forced myself to be active in our class discussion forums. I joined a virtual study group that met on Zoom twice a week. We had a group chat that was a lifeline. A place to ask dumb questions, vent about a tough clinical day, or share a funny nursing meme at 2 in the morning. These people scattered across the country became my colleagues. They were the only ones who truly understood the unique pressure cooker we were all in. They were the ones I could text after a day like that Tuesday, and they would respond not with generic platitudes but with, "Oh my God, I had a day just like that last week. It's the worst. You've got this." That night, standing in my living room on the verge of quitting, I didn't magically feel better. But I ran through my checklist. I did my decompression ritual. I showered, changed, and made myself a cup of tea. I texted my study group, and the immediate flood of supportive messages was a balm on my frayed nerves. I sat down and forced myself to log my small wins for the day. 1. I woke up on time. 2. I was kind to my difficult patient even when I was frustrated. 3. I asked for help when I needed it even though it was hard. It wasn't much, but it was enough. It was enough to quiet the screaming voice in my head, to turn it back into a whisper. It was enough to get me to open my textbook, because surviving that emotional gauntlet was only half the battle. Now I had to face the academic one. I had to somehow conquer the sheer volume of information that separates you from that degree, a mountain of knowledge so vast it feels at times completely insurmountable. And that mountain has a name. It's called pathophysiology, or pharmacology, or adult health 1. Each one is a new peak to summit, and the trail is littered with the ghosts of students who tried to carry too much, who tried to memorize every rock and every leaf on the way up. My first week, I was on track to become one of them. I remember opening the first module for my fundamentals class. It looked simple enough. A few chapters to read, a recorded lecture, a discussion board post, and a 10-question quiz. I can do this, I thought. Then I clicked on the reading assignment. It wasn't a few chapters. It was 173 pages. Pages dense with terminology I couldn't pronounce, concepts that felt completely alien, and procedures that sounded like they belonged in a science fiction movie. The lecture was 2.5 hours long. The discussion board required 3 citations in APA format, and this was just the first module for one class due in 5 days. I had 3 other classes just like it. My initial strategy was what I call the brute force method, the same method that got me through high school and my prerequisite classes. I would be a machine. I would read every single word. I would highlight everything that looked important, which in a nursing textbook is basically every other sentence. I would transcribe the lectures, pausing the video every 15 seconds to write down every the professor uttered. My notes were beautiful, color-coded, and utterly useless. By the end of the first week, I had spent 40 hours studying for one class and my brain felt like a sponge that had been left in the desert. I could barely remember what I had for breakfast, let alone the 6 rites of medication administration. I took that first 10-question quiz and got a 70, a C, the minimum passing grade. I was devastated. I had put in more effort than ever before in my academic life and had barely scraped by. It was a brutal, humbling wake-up call. The brute force method wasn't just inefficient, it was a one-way ticket to burnout and failure. You cannot conquer this mountain by counting the pebbles. You have to learn how to read the map. You have to learn how to find the trail. And that's when I had my epiphany. It didn't come in a flash of light. It came out of sheer desperation, sitting at my desk at 2 in the morning, staring at a chapter on fluid and electrolytes, feeling the weight of that entire mountain pressing down on me. I realized I was approaching this all wrong. I was a student trying to memorize facts, but I needed to start thinking like a nurse. And what's one of the first things a nurse learns to do in a crisis? Treat. You don't treat every patient the same. In a mass casualty event, you have to quickly assess and categorize. Who needs immediate, life-saving intervention? Who is seriously injured but can wait? And who has minor injuries and can be treated last? I decided to apply that same logic to my studies. I called it the academic triage system. My syllabus was no longer a to-do list. It became my patient. The first thing I did was assess it. What were its vital signs? The grading breakdown. The exams were worth 60% of my grade. That's the heart and lungs of the course. The quizzes, 10%. The discussion boards 5%. Important but not the priority. Then I looked at the chief complaint, the learning objectives for each module. These are the golden ticket. Professors don't write them for fun. They are literally telling you, this is what I am going to test you on. This is what you need to know to pass my class and, more importantly, to be a safe nurse. Everything in the course, the readings, the lectures, the assignments, was designed to serve those objectives. Once I had my assessment, I began to triage the information itself. I created a 3-tier system: red, yellow, and green. Red tag information was the equivalent of a patient who isn't breathing. This was the absolute, non-negotiable, need-to-know-it backwards and forwards material. What qualified as red tag? First, anything directly stated in a learning objective. If an objective said, describe the pathophysiology of heart failure, then every single thing related to that, the role of the renin-angiotensin-aldosterone system, the difference between systolic and diastolic dysfunction, the clinical manifestations like jugular vein distension, all of it was red tag. Second, any concept the professor repeated multiple times or explicitly said, you need to know this, or this is a common NCLEX topic. That's a giant flare going up. Pay attention. Third, core safety principles. Things like medication rights, infection control protocols, and patient safety goals. These are the concepts that, if you don't know them, you could actually harm someone in the real world. This red tag material became my entire focus. Next came yellow tag. This was the urgent but stable patient. This is the supporting information that provides context and deeper understanding, but isn't the life or death core concept. It might be the history of a particular treatment, less common side effects of a medication, or detailed statistical data. It's important and it helps connect the dots, but if I was short on time, I knew I could survive by focusing on the red. I would review yellow tag material after I had mastered the red tag concepts for the week. It fleshed out my understanding, turning a black and white picture into color. Finally, there was green tag, the walking wounded. This is the interesting but non-essential information. The little trivia boxes in the textbook, the long historical anecdotes, the highly specific case studies about a 1 in a million disease. In my brute force days, I spent hours trying to memorize this stuff, thinking it made me a better student. With my triage system, I gave myself permission to skim it, or even skip it entirely if I was pressed for time. It was liberating. It was like taking a 50-pound pack off my back halfway up the mountain. Now, a system is useless without the tools to implement it. As an online student, my entire world was digital, so my system had to be too. I lived in a program called Notion, but you could use OneNote or any similar app. I built a template for every single class. Each week had its own page, and on that page I would copy and paste the learning objectives right at the top. They were my North Star. Then, as I watched the lectures or read the textbook, I wouldn't just take notes. I would triage them in real time. I used a simple highlighting system. If a concept was clearly a red tag, I highlighted it in red. Yellow tag, yellow. Green tag, green. My notes were no longer a transcript. They were a strategic blueprint of the course. I could see at a glance where I needed to focus 90% of my energy. This system completely changed how I studied. Instead of passively reading, I was actively hunting for red tag information. It turned study time into a strategic mission, and it fed directly into the two most powerful learning techniques known to science: active recall and spaced repetition. I stopped just rereading my notes, which is one of the least effective ways to learn. Instead, I used my red and yellow tag notes to create digital flashcards in an app called Anki. Anki is a smart flashcard program that uses an algorithm to show you cards right before you're about to forget them. So, my red tag flashcards, the core concepts, I would review them every single day. The yellow tag cards maybe every 2 or 3 days. I didn't even make cards for the green tag stuff. This meant I wasn't wasting precious cognitive energy on low-yield information. I was constantly reinforcing the most critical knowledge, burning it into my long-term memory. For the toughest red tag concepts, the big scary disease processes, I used what's known as the Feynman technique. I would stand in front of a whiteboard in my office and pretend I was teaching it to a 10-year-old. If I couldn't explain congestive heart failure in simple terms, using analogies and avoiding jargon, it meant I didn't truly understand it myself. It forced me to break down complex ideas into their fundamental building blocks. It's one thing to memorize the definition of hydrostatic pressure. It's another thing entirely to be able to explain it like you're talking about a leaky garden hose. That's when you know you own the information. This wasn't just a study hack. It was a fundamental mental shift. I let go of the idea of perfection, of needing to know everything. I embraced the mindset of a clinical professional. Prioritize what will kill the patient. In this case, the patient was my GPA and my future career. This system gave me a sense of control in an environment designed to make you feel like you have none. It transformed my overwhelming mountain of knowledge into a series of manageable trails. So when I sat down at my desk at 6 a.m., I wasn't just studying. I was performing academic triage. I was identifying the red tags for the day, building my flashcard decks, and preparing my strategy for the week. But mastering the information was only one part of the equation. It's one thing to know the material in the quiet of your office. It's a completely different challenge to prove you know it, under immense pressure, when you're facing 100 questions designed to trick you at every turn. Conquering the content was a battle of intellect, but conquering the exams, that was a battle of nerves. And that battle of nerves, it wasn't just a figure of speech. It was a tangible physiological event that happened every 4 to 6 weeks. It started with the notification. Your exam window is now open. And from that moment, a low-grade hum of anxiety would settle deep in my stomach, because a nursing school exam, especially in a rigorous online program, is not like any other test you've ever taken. It's a psychological gauntlet designed to simulate the high-stakes, rapid-fire decision-making of a real clinical setting. They don't ask you, what is the primary function of the sinoatrial node? That's a simple recall question. A first-year biology student could answer that. Instead, a nursing question will paint a picture. It'll say, a 72-year-old male with a history of congestive heart failure is admitted with shortness of breath and a heart rate of 42 beats per minute. His EKG shows a third-degree heart block. Which of the following orders should the nurse question? And suddenly, you're not just recalling a fact. You're synthesizing patient history, interpreting diagnostic data, understanding pathophysiology, and evaluating physician orders all at once. You have to know the function of the SA node, yes, but you also have to know what happens when it fails, what that looks like on an EKG, what the standard treatment is, and which medications would be dangerously contraindicated. And the options they give you are pure evil. They're all plausible. Option A might be a standard medication, but for a different condition. Option B might be the right medication, but at a toxic dose. Option C might be a textbook intervention, but not the priority intervention. And option D might be the correct answer. This is the world of Incilic-style questions, where the goal isn't just to find the right answer, but to navigate a minefield of almost right answers to find the most right one. Then there's the beast itself, the select all that apply question, or SATA. We called them Satan questions for a reason. They give you a scenario and 6 possible answers, and you have to select every single one that is correct. If the correct answers are A, B, and D, and you select A, B, D, and you get the entire question wrong. No partial credit. If you select just A and B, you get it wrong. It's an all-or-nothing gamble that tests the true depth of your understanding. It forces you to treat every single option as its own true or false statement, multiplying the cognitive load of a single question by a factor of 6. Now, imagine facing 100 of these questions back-to-back for 2 or 3 hours straight. And you're doing it all from your spare bedroom. This brings us to the bizarre ritual of the online proctored exam. It's a level of surveillance that feels like you're launching a nuclear missile, not taking a pathophysiology test. First, you have to download their proprietary lockdown browser, a piece of software that takes over your entire computer. It shuts down every other application, blocks every other website, and turns your $1,000 laptop into a single-function machine. Then comes the room scan. You have to use your webcam to give the anonymous proctor, who could be thousands of miles away, a full 360-degree tour of your room. You show them your desk surface, top and bottom. You show them the walls, making sure there are no posters with hidden notes. You show them the floor around you. You have to show them your arms, your ears to prove you're not wearing an earpiece. You hold up your blank scratch paper to the camera front and back. The entire process is designed to make you feel like you're already under suspicion. Once the exam starts, you are on camera and your microphone is live. You cannot look away from the screen for more than a few seconds. If you mumble the question to yourself, you get a warning. If your dog barks in the other room, you might get a warning. If your internet connection flickers for even a moment, the entire exam could shut down, and the fight to get it reinstated is a bureaucratic nightmare. I remember one exam where my upstairs neighbor decided to start vacuuming. The noise was deafening, and I spent the first 30 questions in a state of pure panic, convinced the proctor would hear it through the microphone, assume someone was in the room with me, and invalidate my entire test. I was answering questions about beta blockers while my heart was trying to beat its way out of my own chest. To survive this, I had to develop a system, a pre-flight checklist for my brain. The moment the exam timer started, before I even read the first question, I would perform what's called a brain dump. I'd take my approved single sheet of blank paper and frantically write down everything I was scared of forgetting. Common lab values, medication antidotes, formulas for calculating 4 drip rates, mnemonics for cranial nerves. It was like offloading my brain's RAM onto an external hard drive. It cleared my head and quieted the panic, because I knew the most volatile information was now safe and secure on the paper in front of me. Then, for each question, I had a rigid 4-step dissection process. Step 1. Read the question stem twice. Ignore the answers. What is it actually asking me? Is it asking for a priority action? A patient education point? A sign of a complication? I'd highlight the key words. First, best, most important, needs further teaching. Step 2. Before looking at the options, I tried to answer it in my own head. This prevented me from being seduced by the cleverly worded distractors. Step 3. I'd read each option and treat it as a true or false statement. Is this statement on its own a correct and relevant piece of nursing knowledge for this specific scenario? Step 4. Eliminate. I'd physically cross out the answers I knew were wrong. Usually, you can get it down to 2. And that's where the real nursing judgment comes in. This is where you have to apply the frameworks we drilled 1,000 times. Airway, breathing, circulation. Is one of these options more life-threatening than the other? Does one align with Maslow's hierarchy of needs more fundamentally? Is it safety over psychosocial needs? I'll never forget my final pharmacology exam. It was the gatekeeper course for the entire program. Fail it and you were out. It was 125 questions and I felt like I was drowning by question 10. Every question was a complex scenario about a drug I could barely pronounce, with side effects that overlapped with a dozen other medications. I hit a question about anticoagulants, a SATA question with 6 options about lab monitoring, dietary restrictions, and signs of toxicity. My mind went completely blank. I felt that hot flush of panic, the tunnel vision closing in. I was about to just guess and move on to cut my losses, but then I stopped. I closed my eyes. I took 3 deep breaths just like they teach you to tell patients to do. I looked at my brain dump sheet and saw the little mnemonic I had written for the anticoagulant warfarin, and I started again from scratch. Step 1. What is the question asking? It was about patient education. Step 2. What do I know about teaching a patient on warfarin? I know they need regular blood tests, they need to be consistent with vitamin K intake, and they need to watch for bleeding. Step 3. I went through each option one by one, turning it into a true/false statement based on those core principles. And suddenly, the fog started to clear. I could see the correct answers and, more importantly, I could see why the other answers were wrong. I didn't ace that exam, but I passed. And when I finally clicked that submit button and the session ended, I didn't feel elation. I felt like a soldier who had just survived a battle. I was exhausted, mentally bruised, and utterly drained, but I had survived. And I realized that these exams weren't just about pharmacology or pathophysiology. They were training. They were a simulation in their own way. They were teaching us how to stay calm and think critically when the pressure is on, when the information is confusing, and when a wrong decision has serious consequences. It was the intellectual boot camp for what we would eventually face in the real world. But mastering the knowledge in a controlled digital environment was one thing. Applying it to a breathing, talking, and sometimes crashing high-fidelity mannequin, that was an entirely different universe. And my first experience in the virtual simulation lab was a lesson in humility I would never forget. The room was sterile, cold, and unnervingly quiet, except for the faint rhythmic whoosh of a ventilator and the soft, steady beep of a cardiac monitor. In the center of the room, on a standard-issue hospital bed, lay my patient. His name was Sim Man, and he was the most expensive and terrifying doll I had ever met. He blinked. He had a pulse. His chest rose and fell with each simulated breath. Wires snaked from his body to a bank of monitors displaying a perfect set of vital signs. Behind a one-way mirror, I knew my professors were watching, clipboards in hand, ready to dissect every decision, every hesitation. My partner, another student named Sarah, looked as pale as I felt. We were given our report. A 55-year-old male, admitted for a minor infection, now receiving his first dose of a new intravenous antibiotic. Our task was simple: monitor him for the first 15 minutes. Simple. For the first 5 minutes it was. We made small talk with Sim Man, whose voice came from a speaker in the ceiling, controlled by our instructor. We checked his 4-line. We charted his vitals. It felt like a play, like we were just acting out a scene from a medical drama. Then the monitor started to change. The beeping, once a soothing rhythm, became more insistent, a little faster. The oxygen saturation number, which had been a healthy 98%, dipped to 94. Simman coughed. "I'm feeling a little itchy," the voice from the ceiling said, a slight strain in its tone. Sarah and I exchanged a look. Itchy. That was one of the signs. My brain, a filing cabinet I had spent months meticulously organizing, suddenly felt like it had been kicked over. The drawers flew open, papers scattering everywhere. Anaphylaxis, allergic reaction, urticaria, angioedema, bronchospasm. The words were there, floating in the chaos, but they wouldn't form a coherent thought. "My throat feels tight," Simman rasped. The oxygen saturation dropped to 91. The heart rate on the monitor shot up to 120. The calm, sterile room was now a pressure cooker, and I could feel the heat rising in my face. My first instinct was to just stare. Stare at the numbers, stare at the mannequin, as if my gaze alone could will them back to normal. This is the moment they talk about, the one where the textbook slams shut and reality punches you in the gut. The knowledge is in your head, but there's a chasm between knowing and doing. My hands felt clumsy, my mind a blank slate of panic. I could hear the clock on the wall ticking, each second an eternity. Sarah stopped the antibiotic infusion. Good. That was step 1. My brain finally latched onto something. An acronym. ABC. Airway, breathing, circulation. It was the most basic fundamental principle, the first thing you learn. "His airway is compromised," I said, my voice sounding thin and distant. The words felt foreign, like I was quoting a line from a movie. I grabbed the stethoscope, my hands fumbling with the earpieces. Pressing the cold metal to Simman's chest, I heard it. A high-pitched whistling sound. Wheezing. His lungs were clamping down. This was real. Well, as real as it could get. The panic began to recede, replaced by a cold, sharp focus. It was like my brain finally decided to reboot. The scattered papers in my mind began to organize themselves back into the filing cabinet, not neatly, but in an order that I could use. "We need to sit him up," I told Sarah, my voice now firmer. We raised the head of the bed. It was a small action, but it was an action. It was a choice. We were no longer just observers of the chaos. We were intervening. "I'm calling the rapid response team," Sarah said, picking up the prop phone. While she was doing that, my eyes scanned the room, looking for the emergency equipment. The crash cart. The oxygen. The medications. My instructor's voice, now in her normal tone, came over the intercom. "What are you going to do next, Ashley?" It wasn't accusatory. It was a prompt. A lifeline. My mind raced through the anaphylaxis algorithm I had stared at for hours on my laptop screen. Stop the offending agent. Done. Assess the airway. Done. Call for help. Done. What was next? The one thing that reverses this. The one thing that can open up his airway and support his blood pressure. Epinephrine. I saw the pre-drawn syringe in the crash cart's medication drawer. I knew the dose. I knew the route. I had practiced it on an orange in my kitchen. But injecting a piece of fruit is a world away from injecting a $100,000 mannequin that was actively pretending to die in front of you. I grabbed the syringe. I cleaned the port on his 4-line with an alcohol swab. My hand was shaking, but my mind was clear. I announced the drug, the dose, and the route just as we were taught. I pushed the medication. And then we waited. For 10 seconds, nothing happened. The alarm still blared. The wheezing was still audible. I had a sickening feeling that I had done something wrong, that I had missed a step, that my one shot was a failure. Then, slowly, miraculously, the numbers began to turn. The oxygen saturation crept up from 88 to 92. The heart rate started to come down from the 140s. The wheezing in his chest became less pronounced. The voice from the ceiling, a little weaker now, said, "I think I can breathe a little better." Sarah and I looked at each other, and for the first time we both took a breath. We hadn't saved a life, not a real one. But we had successfully navigated the storm. We continued the interventions, applying oxygen, getting a new set of vitals, preparing for a potential second dose. By the time the simulation ended, the room was quiet again. The monitors back to their steady, reassuring rhythm. We walked out of the sim lab and into the debriefing room, my adrenaline still pumping. I felt like I had just run a marathon. The instructors were there, their faces unreadable. They pulled up the video of our simulation on a large screen. And we watched. We watched ourselves freeze. We watched my fumbling with the stethoscope. We watched the precious seconds we lost to hesitation. It was excruciating. Every mistake, every moment of uncertainty, was laid bare for everyone to see. I wanted to crawl under the table. But then the instructor started talking. She didn't focus on the fear or the fumbles. She pointed to the moment we started communicating. She highlighted Sarah's quick thinking to stop the infusion. She paused the video on the moment I remembered ABC and praised how I verbalized my assessment. She explained that the initial freeze is normal. It's the brain's response to an overwhelming amount of new high-stakes stimuli. The goal, she said, wasn't to be perfect. The goal was to recognize the problem, work through the panic, and act. The goal was to learn. That debriefing was more valuable than any lecture I had ever attended. It was a safe space to fail. In a real hospital, a 15-second delay could be the difference between a good outcome and a tragedy. But here, in this room with a plastic man and a watchful professor, that 15-second delay became my greatest teacher. It burned the anaphylaxis protocol into my brain in a way no textbook ever could. It taught me that it's not about having all the answers instantly, but about knowing how to find them under pressure. It was the first time I felt the immense weight of this profession, but also the first time I truly believed I might be capable of carrying it. I left the sim lab that day completely exhausted but also fundamentally changed. My study habits shifted. I no longer just memorized facts and figures. I visualized them. I ran scenarios in my head while I was making dinner or driving my car. What would I do if this happened? What would I assess first? What is the priority? The simulation had connected the circuits in my brain, turning passive knowledge into the potential for active life-saving skill. It was a controlled fire, designed to forge stronger, more resilient future nurses. And now, I had to see if that forging would hold up in the unpredictable heat of a real hospital with real patients. My first clinical rotation was next week. That week felt like the longest and shortest of my life. Every spare moment was spent with flashcards, rewatching skills videos, and mentally rehearsing conversations with patients I hadn't even met. The crisp, new scrubs hung in my closet like a costume for a play I'd never rehearsed. This was the moment of truth for online nursing education. Could pixels and simulations truly prepare someone for the profound, messy reality of human care? The imposter syndrome was deafening. I felt like a fraud who had memorized the right answers but had no idea how to actually be a nurse. Every fiber of my being screamed that I wasn't ready, that I'd missed some crucial, tangible lesson that only comes from being in a classroom. But there was no turning back. The alarm went off at 4:30 in the morning. It was a dark, cold, and unforgiving sound, but I'd never gotten out of bed faster. I put on the scrubs and they felt stiff and foreign. They weren't just clothes, they were a declaration. A symbol of a threshold I was about to cross. I checked my bag for the 10th time. Stethoscope, penlight, bandage scissors, black pens, a tiny notebook, my school ID. Each item felt impossibly heavy with responsibility. The drive to the hospital was a blur of streetlights and nervous energy. My heart was a drum solo against my ribs. I parked in the massive employee garage, the concrete structure echoing with the footsteps of hundreds of other healthcare workers starting their day. I followed the river of scrubs and clogs, a silent current of people all moving toward the same purpose. Walking through those automatic sliding glass doors felt like entering a different world. The air itself changed, that unique, sterile, yet undeniably human smell of a hospital. It's a scent of antiseptic, floor wax, and something else. Something you can't quite name. It's the smell of hope and fear, of life beginning and ending, all at once. My clinical group met our instructor in the lobby. She was a seasoned nurse, calm and direct, her eyes missing nothing. She handed us our assignments, a slip of paper with a room number and a name. My hands were shaking so slightly I hoped no one would notice. Room 314. We walked onto the medical surgical unit. And that's when the simulation ended and reality hit me like a physical force. It was a symphony of controlled chaos. The rhythmic beeping of 4 pumps, the soft chime of a call light, the squeak of rubber-soled shoes on linoleum, hushed conversations at the nurse's station, the distant moan of someone in pain. It was everything all at once. My preceptor, the registered nurse I'd be shadowing, was named Sarah. She was in her late 30s, moving with an efficiency that seemed almost supernatural. She gave me a quick, kind smile, but her eyes were already scanning monitors, checking charts. There was no time for a gentle orientation. It was time to jump into the deep end. Room 314, she said, pointing down the hall. Mr. Henderson, 82 years old, came in with pneumonia. Also has a history of congestive heart failure. He's a little weak, a little confused, and he's a fall risk. We're going to do his morning assessment and give him his meds. You're on vitals first. Go. Just like that. Go. I took a deep breath, grabbed a blood pressure cuff and thermometer from the supply cart, and walked toward room 314. My mind was racing, trying to recall the exact steps from the online module. Palpate the brachial artery. Cuff 2.5 centimeters above the antecubital fossa. Inflate to 30 millimeters of mercury, above the loss of the radial pulse. It was a clean, perfect algorithm in my head. But as I pushed open the door, the algorithm dissolved. Mr. Henderson was a small, frail man, swallowed by the hospital bed. His skin was like thin paper, and his breath came in shallow, rattling gasps. He looked at me with cloudy, fearful eyes. He wasn't a case study. He wasn't a mannequin. He was a person. A husband, a father, a grandfather. And he was scared. All the clinical knowledge in the world suddenly felt secondary to the simple, overwhelming need for human connection. "Good morning, Mr. Henderson," I said, my voice higher than usual. "My name is. I'm a student nurse, and I'm here to take your vital signs. Is that okay?" He just blinked at me. I took that as a yes. I gently wrapped the cuff around his fragile arm. His skin was cool and delicate. As I inflated the cuff, my own heart was pounding so loud I was afraid the stethoscope would pick it up. 148/92. A little high. Heart rate 96. Respers 22. Temperature 99.1. I wrote them down in my little notebook, my hand so clammy the pen kept slipping. Sarah came in behind me. "Good," she said, looking at my notes. "Now let's talk to him. A big part of the assessment is just listening. Not just to his lungs, but to him." She leaned over the bed. "Mr. Henderson, how are you feeling this morning? Did you sleep okay?" He mumbled something she couldn't hear. She leaned closer, her posture open and patient. "I'm sorry, sir, can you say that again for me?" "My wife," he whispered, his voice raspy. She always brought me coffee." My heart broke into a million pieces. In that moment, he wasn't just a patient with pneumonia and CHF. He was a man who missed his wife and the simple comfort of his morning routine. Sarah didn't miss a beat. She gently patted his hand. "I know, sir. It's hard being here. We'll get you some coffee with your breakfast tray, I promise." She then turned to me. "Okay, head-to-toe assessment. You start. Talk me through what you're seeing and hearing." And so I did. I started at his head, checking his orientation. I listened to his heart, the loop dub a little faster than it should be. I listened to his lungs, and for the first time I heard it. The sound my textbook had called crackles. It wasn't a recording from a website. It was the sound of fluid in a real person's lungs. It was terrifying and fascinating. I checked his skin, his circulation, the edema in his lower legs. Every step was a clumsy dance of trying to remember the clinical procedure, while also trying to be a compassionate human being. I was so focused on the technical skills that I almost forgot the man in the bed. My biggest challenge came with his 4. His morning antibiotic was due, and I was supposed to flush his peripheral 4 line with saline to make sure it was patent before hanging the bag. I had practiced this 100 times on a rubber arm in my skills kit at home. But a rubber arm doesn't flinch, doesn't have veins that roll. I cleaned the port, attached the saline flush, and tried to push. It wouldn't budge. Panic set in. Did I do something wrong? Was it clotted? Am I hurting him? Mr. Henderson winced slightly. "It's okay, honey," he rasped. "They always have trouble with me." Sarah stepped in, her presence instantly calming. "No problem," she said to me, not to him. "It happens. Let's look. See how it's a little red right here? It's probably infiltrated. We're going to have to restart it. You've done this in the lab, right?" I nodded, my throat suddenly dry. "Okay," she said. "I'll walk you through it. But you're going to do it." The next 10 minutes were an eternity. Finding a new vein on an elderly, dehydrated patient is one of the most difficult skills for a new nurse. My hands trembled as I gathered the supplies. I could feel Sarah's eyes on me, not with judgment but with expectation. I tied the tourniquet. I searched his arm, a roadmap of thin, fragile veins. I found one that looked promising. I cleaned the site, anchored the vein with my thumb, and took a deep breath. "Okay, Mr. Henderson, little poke on 3. I advanced the needle. I missed. A tiny bead of blood formed on his skin. I felt a hot flush of shame creep up my neck. I had failed. I had hurt him. I pulled the needle out, applied pressure, and apologized profusely. "Don't you worry," Mr. Henderson said softly. "Third time's the charm. Sarah just handed me a new catheter. Try again," she said. "A little lower. And change your angle. You're coming in too steep. Remember the 30-degree angle from your module." Her words grounded me. She wasn't angry. She was teaching. This wasn't a test I had failed. It was a lesson I was learning. I took another breath, refocused, and tried again on a different site. This time, I visualized the animation from my online course, the needle piercing the vessel wall. I felt the tiny pop and saw the flash of blood in the chamber. I had hit it. I advanced the catheter, pulled the needle, connected the tubing, and flushed it with saline. It flowed perfectly. The relief that washed over me was so profound it almost made me dizzy. By the end of the 12-hour shift, every muscle in my body ached. My feet were throbbing. My brain was a swamp of new information, names, and procedures. I had helped Mr. Henderson to the bathroom, changed his linens, documented his intake and output, and listened to him tell me a story about how he met his wife at a dance in 1958. I wasn't just a student anymore. I had touched a life. I had been a part of a team. I had taken the abstract knowledge I'd learned through a screen and applied it with my own two hands. Walking back to my car in the dark, the hospital glowing behind me, I finally understood. Online learning gave me the what and the why. It built the foundation, the scaffolding of knowledge. But clinicals were about the how. And more importantly, they were about the who. It wasn't about passing a test or getting a grade. It was about earning the trust of someone like Mr. Henderson. I had survived my first day. I had made mistakes, but I had also learned. I had been terrified, but I had also been brave. And as I drove home, I knew one thing for sure. This was just the beginning. The next day, I was assigned to the pediatric wing. And no amount of simulation could prepare me for that. The doors to the pediatric wing slid open with a soft whoosh, and it was like stepping into another universe. The sterile beige and white world of the adult floors was gone. Here, the walls were painted in bright, cheerful colors, with cartoon animals and superheroes smiling down from every corner. The air, instead of smelling faintly of antiseptic and illness, carried the scent of baby powder and something vaguely like fruit snacks. But the biggest difference wasn't the decor. It was the sound. It was a symphony of noise, the high-pitched beeping of smaller machines, the gentle lullaby music drifting from a mobile, the distant sound of a cartoon on a television, and underneath it all, the most gut-wrenching sound in the world, a child crying. Every instinct in my body screamed that I didn't belong here. I felt like a giant clumsy oaf in a world built for tiny, fragile people. My scrubs felt too big, my hands too rough, my voice too deep. In the adult med-surg unit, I was dealing with people who, for the most part, understood what was happening to them. They could tell me where it hurt. They could consent. Here, my patients were a mystery. Their bodies operating on a completely different set of rules. Their minds unable to grasp why strangers were poking and prodding them. My preceptor for the day was a nurse named Maria. She had a calm, warm energy that seemed to create a bubble of peace around her. She saw the deer in the headlights look on my face and gave me a small, knowing smile. "It's a lot to take in, isn't it?" she said softly. "Just remember one thing. They're not little adults. Everything is different. Their anatomy, their physiology, how they process medication, and most importantly, how they see the world. Your job isn't just to treat their illness. It's to protect their childhood while you do it. Protect their childhood." The words echoed in my head. I'd been so focused on learning the clinical skills, the different vital sign parameters, the weight-based dosage calculations that had to be perfect down to the microgram, that I hadn't even considered the psychological aspect. Our first patient was a 5-year-old boy named Leo. He'd had his tonsils out the day before and was refusing to drink anything. His chart said he was at risk for dehydration, which could lead to a whole cascade of serious problems. Simple task, I thought. Get a 5-year-old to drink. How hard could it be? The answer I soon learned was impossibly hard. We walked into the room, and Leo was a tiny ball of misery huddled in a bed that seemed to swallow him whole. His face was puffy from crying, and he had his arms crossed tightly over his chest, a miniature fortress of defiance. His mom and dad were sitting on either side of the bed, their faces etched with a weary anxiety that every parent knows. They looked at me, the student, with a mixture of hope and deep suspicion. Maria introduced me, and I smiled my brightest, most non-threatening smile. "Hi, Leo," I said, my voice coming out an octave higher than usual. "I'm your nurse today. I heard you're a superhero for getting your tonsils out." He just glared at me from under his furrowed brow. His mom sighed. "He won't drink anything. Not water, not juice, not even the popsicle we brought him. He says his throat hurts too much. We need to get some fluids in him, buddy," I said, trying to be cheerful as I held up a small cup of apple juice with a crazy straw. "This will help you feel so much better." He shook his head violently, tears welling up in his eyes again. "No, it hurts," he wailed. I looked at Maria, helpless. She gave a slight nod, a silent permission to keep trying. I spent the next 10 minutes trying every trick I could think of. I made the cup of juice a rocket ship. I pretended the straw was a snake. I offered to have a tea party. Nothing worked. Every attempt was met with a tearful, stubborn no. The parents' faces grew tighter with worry, and I could feel my own confidence evaporating. I wasn't just failing to complete a task. I was actively causing this little boy and his family more distress. Finally, Maria gently put a hand on my arm. "Let's step outside for a second," she whispered. In the hallway, my cheeks were burning with embarrassment. "I'm sorry," I mumbled. "I don't know what to do. I'm making it worse." Maria leaned against the wall. She didn't look disappointed. She looked thoughtful. "You're doing what you were taught in the book," she said. "You're trying to reason with him, to bribe him, to distract him. You're trying to be a nurse. But right now, Leo doesn't need a nurse. He needs a translator. He's scared, he's in pain, and he's 5. His entire world has been turned upside down. He has no control. Your job is to give him some of that control back, but in a way he understands." "How?" I asked, completely lost. She pointed back toward the room. "What do you see in there?" "A sick kid. Worried parents. A hospital bed." "Look closer," she urged. "What is Leo wearing?" I peeked through the window in the door. He was in little blue pajamas covered in dinosaurs. A T-Rex, a Stegosaurus, a Triceratops. "Dinosaur pajamas," I said. "Okay," Maria said. "Dinosaurs. Work with that. And stop talking about fluids and dehydration. You're speaking a foreign language. Speak dinosaur. Speak dinosaur." It was the strangest and most profound piece of advice I had ever received. I took a deep breath, squared my shoulders, and walked back into the room. This time I didn't go for the juice. I didn't even look at it. I walked over to the bed and crouched down so I was at eye level with Leo. "You know," I said in a low, conspiratorial voice, "I have a big secret. The doctor told me that after they take your tonsils out, they put a baby T-Rex in your throat to protect it. But the baby T-Rex gets really, really thirsty. And if he doesn't get a drink, he gets super grumpy and starts stomping around, and that's why it hurts so much." Leo's crying hitched. He looked at me, his eyes wide with a flicker of interest. His parents exchanged a confused but curious glance. I kept going. "We have to give the baby T-Rex a drink. To make him strong. This apple juice," I said, picking up the cup, "isn't for you. It's special T-Rex power juice. It makes his roar super quiet so he doesn't tickle your throat anymore. We just have to sneak it past your teeth so he can drink it." A tiny smile played on Leo's lips. He looked at the cup, then back at me. Is it red like a T-Rex?" he whispered, his voice raspy. My heart leaped. He was engaging. "No," I said, thinking fast. "It's yellow like a super-fast velociraptor. We have to drink it fast, before the grumpy Stegosaurus in your tummy tries to steal it." I put the crazy straw to his lips. He hesitated for just a second, then took a tiny, tentative sip. His eyes widened as the cool juice slid down his throat. He took another sip and then another. He drank half the cup before pulling away, a look of profound accomplishment on his face. His mom let out a breath she must have been holding for hours. His dad was just staring at me, his jaw slightly slack. I looked over at the doorway and Maria was standing there beaming. In that moment I understood. This was nursing. It wasn't just about IVs and assessments and medication passes. It was about connection. It was about creativity. It was about crawling inside another person's reality, whether they're 95 or 5, and meeting them where they are. I spent the rest of the shift not as a nursing student, but as a dinosaur tamer, a spaceship captain, and a secret agent on a mission to deliver magic potions. We conquered Jello mountains and navigated popsicle forests. By the end of the day, Leo was sitting up, chatting away about his favorite pterodactyl, his pain managed, and his hydration status improving. As I was charting, Leo's dad came up to the nurse's station. He looked at me, his eyes a little misty. "Thank you," he said, his voice thick with emotion. We were so worried. We didn't know what to do. You didn't just give him juice. You gave him his imagination back. You reminded us that he's still our little boy, not just a patient." I drove home that night not with the adrenaline-fueled exhaustion of my first code, but with a deep, quiet sense of fulfillment. I had learned more about patient care from a 5-year-old in dinosaur pajamas than any textbook could ever teach me. I had learned that the most advanced medical technology in the world is useless without the simple, ancient art of human connection. I was starting to feel like I was finally getting it, like I might actually be good at this. And as I pulled into my driveway, my phone buzzed with an email. It was my clinical assignment for the following week. 2 words stared back at me from the screen that made my blood run cold. Neonatal intensive care. Neonatal intensive care. The NICU. The 2 letters that every nursing student whispers with a mix of awe and absolute terror. This wasn't the med-surg floor with its predictable rhythms. This wasn't the ER with its controlled chaos. This was the place where life was measured in grams and breaths per minute, where the patients were the most fragile, the most vulnerable human beings on the planet. And they were assigning me to it. Me, the online student who still triple-checked how to program in 4-pump for a full-grown adult. My mind spiraled. All the confidence I had built up just hours before evaporated, replaced by a cold, creeping dread. What if I messed up? A medication error on an adult is serious. A medication error on a 1-pound preemie. It's unthinkable. I felt like a fraud. How could my online modules, my simulations, my carefully constructed care plans on a computer screen possibly have prepared me for this? That night, sleep was a fantasy. I didn't just review my notes. I went on a deep dive. I spent hours watching procedural videos from registered nurses who specialized in neonatology. I learned about surfactant administration for underdeveloped lungs, phototherapy for jaundice, and the intricate dance of managing temperature in an isolette. I read about necrotizing enterocolitis, patent ductus arteriosus, and retinopathy of prematurity. These weren't just vocabulary words anymore. They were potential battles I would be witnessing firsthand. I practiced my dosage calculations over and over, using neonatal weight conversions. The numbers were terrifyingly small. Milliliters became microliters. Decimal points were the difference between therapy and tragedy. I felt like I was cramming for the most important exam of my life, except the grade wasn't a letter on a transcript. It was the well-being of a child. By the time the sun came up, my eyes were burning, but my brain was buzzing with a nervous, focused energy. I couldn't say I was ready, but I could say I had done everything in my power to not be completely useless. Walking into the NICU for the first time was like stepping onto another planet. The normal hospital hustle was gone, replaced by a library-like quiet. The only sounds were the soft, rhythmic beeps and whirs of monitors and ventilators, a symphony of survival. The lights were dimmed, creating a calm, womb-like atmosphere. And everywhere, there were these tiny little pods, these clear plastic isolettes, each one a self-contained universe for a miniature human fighting a giant's battle. I felt huge, clumsy, and loud. My preceptor, a nurse named Maria with kind eyes and an air of unshakable competence, met me at the door. She didn't smile much, but she looked at me with an intensity that said, "I see you're terrified. Don't mess this up." She assigned me to a single baby. His name was Liam, and he was born at 29 weeks. He weighed just over 2 pounds, and he fit perfectly in the palm of my hand, if I had been allowed to hold him. He was covered in a web of wires, heart monitor leads, a pulse oximeter on his tiny foot, a temperature probe on his stomach. A feeding tube ran through his nose, and he was under the gentle blue glow of the Billy lights. My job for the first few hours was simple. Observe. Watch Maria. Learn the rhythm of the room. I charted his vitals every hour. I watched how she meticulously measured out formula and administered it through his feeding tube, drop by drop. I watched how she changed his diaper. A diaper no bigger than a credit card, through the portholes of the isolette, with movements so gentle and deliberate, it was like watching a bomb disposal expert. My first real task was to take his temperature. My hand was shaking as I reached into the isolette, terrified my touch would be too cold, too rough. Maria watched my every move. I gently placed the thermometer under his arm, my heart pounding in my ears, louder than all the monitors combined. When the number came back stable, I felt a wave of relief so profound it almost made me dizzy. It was the smallest of tasks, but it felt like a monumental victory. Later, Maria talked me through drawing up his medications. It was a cocktail of caffeine to stimulate his breathing and a vitamin supplement. The syringes were tiny, the measurements infinitesimal. She had me show her my math, then show her again. Then she watched me draw up the exact amount. As I pushed the liquid slowly into his feeding tube, I understood. This wasn't just about medicine. This was an act of profound trust. His parents were trusting us. The doctors were trusting us. And for that moment, Maria was trusting me. The turning point of the day, of my entire nursing school experience, came in the afternoon. Liam's mom arrived. She was young, and her face was a mask of exhaustion, fear, and a love so fierce it was almost tangible. She couldn't hold Liam yet. He was still too unstable. So she just stood by his isolette, her hand resting on the plastic as close as she could get. She spoke to him in a soft whisper, telling him about his nursery at home, about his dad, about the dog waiting to meet him. Maria was busy with another baby, and for a few minutes it was just me and Liam's mom. She looked over at me, her eyes filled with tears. She asked, "He's fighting, isn't he?" "He's a little fighter." And without thinking, all the textbook knowledge, all the pathophysiology, all the clinical jargon just fell away. I looked at the monitors, at his steady heart rate, his oxygen saturation holding in the 90s. I looked at his tiny chest rising and falling. And I looked at her. And I said, "He absolutely is. He's one of the strongest people I've ever met." A small, genuine smile broke through her tears. And in that moment, I wasn't an online student. I wasn't an imposter playing dress-up in scrubs. I was a part of this baby's care team. I was a source of comfort for his terrified mother. The connection between the late-night lectures on respiratory distress syndrome and this mother's hope was suddenly crystal clear. The online discussion posts about therapeutic communication became a real conversation that mattered. Every single hoop I had jumped through, every exam, every simulation, it all funneled down to this one single human moment. It was the why. The big flashing neon sign why I had been searching for. Driving home that evening, the world seemed different. The setting sun was more vibrant. The music on the radio was more beautiful. I was bone-tired, my feet ached, and my brain felt like it had run a marathon, but I was buzzing with a purpose I had never felt before. The fear was still there, of course. But it wasn't the paralyzing dread from the night before. It was a healthy fear, a fear born of respect for the responsibility I was being given. I finally understood that nursing school, whether it's online or in a traditional classroom, isn't about making you fearless. It's about teaching you how to function, how to be safe, and how to be compassionate right alongside that fear. It's about showing up even when you're terrified because someone smaller and more terrified than you needs you to be there. This journey, which started with me sitting alone at my kitchen table, staring at a computer screen, had led me here, to the front lines of human vulnerability and resilience. And I knew with a certainty that settled deep in my soul, that I was exactly where I was supposed to be. The login screen was just the door. This was the room where I belonged.